So welcome to Inner South Community Health's Bayside Alcohol and Other Drug Services information session. Today we're going to be talking about a bit of an overview of how the changes to the drug and alcohol system have happened. We'll also be talking a bit about how Bayside Alcohol and Drug Services operate, what the AOD treatment types are available to services in terms of consumers' access and different types of supports. We talk a bit about family, significant others, in terms of what's available to them and how they can be supported to help their own access drug and alcohol services. We're also going to provide a bit of information for professionals around how they can support consumers to access treatment. And after that, we'll have a little bit of an information session around what after hours looks like and any questions that might be relevant to people accessing drug and alcohol support. So as of 2014, the state government reformed the drug and alcohol sector. So on September 1st, they changed how people would access drug and alcohol treatment. It all went central intake. So what it means for consumers now is that it all goes through a regional-based central intake point, which are then responsible for referring people into treatment types. Now, it's a statewide reform, so what that means is that for people looking to be referred into counselling, family counselling, residential withdrawal, residential rehab, non-residential withdrawal, care and recovery coordination, they all come through central intake now, and I'm going to talk a bit more about those different treatment types in detail soon. But in respect to pharmacotherapy, that's still directly accessible via a GP. Having said that, central intake providers also work with consumers and GPs to access that type of support. And look, the central intake service supports anyone really, but I mean, in terms of service provision, it's for 16 and upwards. And for the Bayside AOD service, what we do is we cover the cities of Port Phillip, Glen Eira, Bayside, Stonnington and Kingston.
So in terms of how the process works in order to get clients linked in, essentially what we need clients to do is to complete an initial screen which takes 20 minutes, half an hour to complete. It's a series of questions, and at the end we collect certain information that allows us to see whether they're eligible or not. So from there, from that information, it's generally done over the phone, can be done face-to-face through information sessions, but we'll talk about that later. But then they'll be booked in for a comprehensive assessment, which goes on for around 60 minutes, give or take. That can be done over the phone or face-to-face. There's an alternative option in completing that initial screen, so they don't have to do it over the phone. They can actually download, the clients can download the document, or workers can download the document as well. So the beauty of that is that they can complete it in their own time, or if they feel that their time is better used doing that initial screen with their client, then they can do that. Or the client can do it in their own time as well, and they can send it through and upload it onto the website.
What does that mean for clients who might re-present? So say someone kind of goes out of the system and then nothing much has changed 6 months later, do they have to go through the process again, or would that be on file and then...
So yeah, great question. In a sense, what we will do with that information that we've got in the past is we will update the information that we've got there, so they don't have to retell their story. It allows us to see, it's good because we can see how they've changed, whether they've got worse or better, if you will, for a better way of describing that, and also to see what behaviours have changed and stuff in the assessment, the comprehensive assessment as well. Do you want to add anything to that?
Yeah, I mean, look, I guess if we're talking about 6 months ago, there's been some changes. We're probably just going to update that information around, if there's changes to medication, hospital admissions, new professionals linked in, and what has potentially not worked in the past. So if they typed a particular type of treatment that wasn't too successful, or there was some scope for something that needs to be added to make that a little bit more goal-driven, if you like, or specific to that client's need, then we're going to talk about that as part of redoing all that assessment work, if you like. So potentially if they tried a non-residential withdrawal episode, which we'll talk about soon, and that had some limitations around being supported adequately, we'd be talking to the client about potentially considering residential withdrawal. Did they attend their appointments with their drug and alcohol counsellor? What worked, what didn't work, what can we do differently this time? So it's really about trying to just provide a little bit more support in terms of what the client is identifying are some of the gaps in that last attempt to address their AOD usage. And look, in terms of the goal-specific type of stuff, I guess it really is about what they want to achieve. Some clients aren't looking for a complete abstinence. They're looking to address it potentially around reducing the harms associated with what they're doing.
Yeah.
So we can work with that. It really is about what's in their best interest and what they're ready to take on board as a challenge.
So when we've completed the assessment, and I suppose it's kind of linking with what Peter was saying right there, is we'll develop a treatment plan that's around their needs that they've set at that time. So we try and gather their goals, what they're wanting to work on, and it's not necessarily AOD specific, so alcohol and other drugs specific, sorry. So that can be around their legal support, it could be around their health, it could be about their relationships. It's a really holistic kind of view that we have there if they have those goals. And then from there, we'll see services that we need to refer them to that can help them with those goals. You can contact us through telephone, so the numbers are up there. We are available Monday to Friday, 9 to 5. What I suggest with initial screens, though, for clients and calling us up to complete them, try and do it before 4:30, because after then, at least it allows us to give them that time and space to do an initial screen in that half an hour. The website's up there as well. There's also an information session that's similar to this kind of scenario here that we do on Fridays. It's from 1 p.m. And it's available for around about 2 hours, I think, isn't it? It's just held at Paran, so 240 Malvern Road as well. We can go through this information here comprehensively. It's more interactive, I suppose, with clients, and we can do an initial screen in that time with them as well.
And look, what I'll do now is I'll talk a bit about the AOD treatment types that are specifically what central intake refer into. So that is that without actually doing an initial screen and an assessment, we can't get people into these particular types of drug and alcohol intervention. So AOD counselling is session-based. It's one-on-one work with an AOD specialist counsellor who will explore different types of strategies around focusing on potentially harm minimisation or relapse prevention, and then any other goals, whether it be around managing anxiety, potentially relationship concerns, and some of the other things that Chloe alluded to a little earlier. Some of the other things that we're referring into quite frequently are residential services. So withdrawal, which is otherwise known as detox, is a 7 to 10 day stay, and it's a statewide service that we can refer into. So there are a lot of services that are on offer, and some of them have different criteria, but being a central intake provider, we know what might match for clients. So that's really what it's about, trying to get clients into a program that's actually going to fit for them so that they can actually have that period of withdrawal. Quite often when we do refer into that 7 to 10 day stay, we're prepping clients around what that might look like. So essentially, it's 24-hour staff supported. A lot of these services have 24-hour nursing care. They work with GPs who are addiction specialists who also work out a withdrawal regime around what's going to be adequate for them in terms of minimising the risk when they are ceasing drug and alcohol usage. And then we're often trying to tailor that post-withdrawal plan with a particular AOD intervention that might include counselling, potentially some outreach support, and maybe any other supports that might be suitable, like NA, AA, which are peer support kind of drug and alcohol frameworks that help people to a 12-step abstinence model. Some of the other services are residential rehab, and it really varies. So there are a lot of statewide services again available. It's 6 weeks to 12 months depending on which rehab we refer to. And it's one of the things that probably is on most highest demand in terms of what's available for beds. So clients can actually end up waiting quite a while before they get into a rehab, and it's probably the most difficult treatment in terms of wait periods. What we do with clients who are really keen on accessing that is try to get them into other drug and alcohol services to support them to work towards their goals around entering long-term rehab. So we can really support them around that length of time as well. Non-residential withdrawal is about trying to complete a detox, if you like, whilst you're in the community. So that particular treatment type has nurses who assist the clients to access their own GP, or if they don't have their own doctor, find a local GP in the area who can support them to do the withdrawal. Once again, that'd be medically supervised by the GP and the nurses, and that treatment type is generally speaking probably about 2 weeks of intensive withdrawal support, followed by another 2 weeks of more supportive kind of assistance, but not necessarily more around the withdrawal side effects, but more so around just trying to keep that person really goal focused around achieving those initial withdrawal plans, if you like, or goals. The care and recovery coordination is something really new. So prior to September 1st of 2014, there wasn't outreach AOD specific kind of intervention. And the way that treatment type looks at this stage is that it's pretty intensive kind of case management work, but it's short term. So that is that for clients who are looking to get coordination around accessing lots of different services, potentially needing a lot of help around accessing things like housing, financial support, whatever it might be really, these workers are really geared towards getting all that happening in a quick time frame, and if necessary, looking at getting them into longer term case management wherever appropriate, wherever that service might exist. The other thing obviously that we're working towards is pharmacotherapy intervention where that's appropriate. So that's liaising with communities, community GPs I should say, so making sure that we're letting clients know who's available, what's on offer, what that particular support might look like, and quite often GPs are contacting central intake too around a particular patient that they're working with might have withdrawal needs or they might need AOD counselling needs. So we're just trying to make sure that wherever possible we're supporting people to access pharmacotherapy. Does anyone have any questions about those treatment types? Is that pretty clear?
This is all in the Bayside area, these interventions, is
yeah,
that right?
That's absolutely right. So I guess aside from the residential settings, so the detoxes and the rehabs, we can refer outside of the Bayside catchment. So for example, if someone needed a medical withdrawal, so more inpatient kind of stay in a hospital setting, we'd be referring to Western Health's Drug Health Services, which are in Footscray. So even though they're outside of Bayside, because they're a state funded service, we'd refer into them. But for all the community supports like non-residential withdrawal, AOD counselling, CRC, what we want to do is make it really close to where that person is. So we're trying to get them, locally based in terms of that support. And then the rehabs being, kind of really mostly based in rural communities. Clients would travel there, but they're obviously going to be travelling and staying up there for quite a lengthy period of time. Look, the other thing that hasn't been talked about and isn't up on this slide because it's actually quite new is the day programs. So that is, at this stage, there's a drug and alcohol day program in Narre Warren that's just probably opened up about 1 or 2 months ago, and that's with Regen. And what we do is we refer into that the same way we'd refer into a rehab. But what they would do is they'd probably be going day to day to access support Monday to Friday in kind of an intensive psychoeducational group setting. So a lot of that might be centred around some of that drug and alcohol kind of goal setting information that professionals provide, but it also provides a lot of recreational kind of therapeutic interventions. So whether that would be artwork or something along the lines of therapeutic engagement that isn't really AOD specific, that's also on offer. For clients accessing that, we'd also try to couple it with detox so that when they are going into those rehabs, they're kind of ready to do that. They're not going through withdrawal because the prerequisite is that they're actually in recovery. They're sort of at that action stage of change, if you like. And then we'd also be looking potentially to get them in with some one-on-one counselling. Any other questions?
I'm just interested in how to engage. I do home visits, allied health with an OT, and if I note that there are, drug or alcohol evidence of issues with it, when I'm out there, just really approaching it in a really good way, because I'm building up a relationship with a client. That's really important to have a really good relationship with them. It's not confronting, but also just a way of raising it. I don't know if there's any suggestions, but just I'm aware that if I can see that there are some issues, how to raise it in a way that's really good and productive and not going to be taken the wrong way. Or, are there any, if there's any general advice with that?
Yeah, I mean, sure. Look, I would probably just ask the question. I mean, having worked in AOD for over 10 years, I find that being really direct around it's probably just a really healthy approach, and all that non-judgmental work that we do with clients anyway, I think is really transferable to AOD. So that if someone's talking about, or if they're appearing substance affected, I'd just be asking, hey, have you been using any drugs or alcohol? Do you want to tell me a little bit about what's going on? And once I've got a sense of what that might look like, I can ask them around whether or not they're interested in getting some support. And that might potentially be an approach to maybe open up that conversation. We're certainly available for secondary consults, so we can talk a bit about what we would recommend if that person's wanting to access treatment. But even if they're not, and they're kind of not at that stage where they're identifying the AOD usage as problematic potentially. It's a dialogue to just keep engaged and get a sense of what's going on. So I'd just sort of open it up and ask, yeah. I mean, look, they're going to tell us where to go if they don't want to hear it, right? But I think, look, generally speaking, once you ask that question and it's pretty apparent that there is something happening, if they're ready to talk about most things, the AOD stuff will probably come out as well.
And it may be a huge sigh of relief for them as well. I mean, if you've seen it, then they may be actually like, I've given you invitations, I'm waiting for you to ask me, so it could be things like that.
Maybe timing as well, down the track when I've seen someone a couple of times, but not always on this first visit when you know, it could be all too much at once as part of my assessment. Maybe getting a relationship and then talking about that, you know, in the course of the, you know, seeing them.
Great suggestion.
Yeah, I mean, look, you're going to read your clients, you know, better than anyone, I guess. But I think for most people who are experiencing drug and alcohol usage, there is some guilt and shame around it. But I think what happens naturally with any kind of therapeutic relationship is that once that rapport's kind of there, and whether that happens quickly or it might take some time, clients are pretty reasonable around talking about what some of those harms might be in terms of, you know, that usage affecting their mental health, their finances, potentially relationship difficulties with others. So once it's kind of brought out in the open, I think there's a lot of good work that can be done with that. So it's probably important that if you think it's happening, to just put it out there